Assalamu alaikum warahmatullahi wabarakatuh. Now, welcome to the second part of our discussion regarding the anti-epileptic drugs. Now, first of all, we will continue with our classification. Now, this is the second way of classifying the anti-epileptic drugs according to their clinical usefulness. The first one is the list of drugs or groups which are useful for the partial and both generalized tonic-clonic seizures, in which there are some argentine derivatives, phenytoin, fosphenytoin, mephenytoin, ethotine, etc., aminostilbenes, carbamazepine, etc., barbiturates, phenobarbital, primidone, etc., GABA and glycine analog, vigabatrin, gabapentin, etc., sulfonamide derivatives, including zosamide and antipholumetragine. Then only useful for generalized seizure, usually succinimides, ethosuximide, and the other related salts, valproate derivative like valproic acid and its salts, and oxazolindidiones, but this group is rarely used, trimethadione, etc. And the mixed acting drugs involving benzodiazepine like diazepam, lorazepam, clonazepam, etc., and the carbonic anhydrase inhibitor istazolamide. And then among the miscellaneous group, some bromide sites like potassium bromide and sodium bromide, very old group, and acetylureas, and among the other, pyraldehyde, still in some condition of fits, very useful drugs. So these were the clinical usefulness of these anti-epileptics. Now remember, all the currently available anti-seizures drugs are only having palliative effectiveness. They are not curative at all. All existing anti-seizure drugs, no doubt they provide adequate seizure control in about 2/3 of the patient. But the problem is development of drug resistance in majority of the patients after a period of relatively successful therapy. The possible mechanism of these resistance may be some impaired access of the drug to the target sites, or there may be these target molecules become insensitive to the drugs available molecule there, or some problem in the children and adults. In the children, there are some condition in which there is progressive brain damage which is not responding to these currently available treatment. And similarly, adults, there may be some focal seizures which are not responding to the currently available medication. Some particular temporal lobe lesions are there which are usually removed surgically, and to some extent the benefits are available after surgical removal as far as these seizures are concerned. There may be some other non-medical approach, that is through vagus nerve stimulation. Here, this methodology is adoptive, in which the groups are not responding to the currently available drugs, or in patients who are not tolerating these drugs. Use of these devices may permit seizure control with low doses of drugs also. Now let's start discussing the individual drugs. Now first of all, the most important one is phenytoin, which is one of the argentine derivative. The brand name of phenytoin, its common name is Dilantin. And remember, this is the oldest, number one. And number two, it's non-sedating in its usual therapeutic dosage. And it is effective against all types of partial and generalized tonic-clonic seizure, and even acute treatment of status epilepticus. But phenytoin is not useful against absences. This is the one of the Viva question and the MCQs also. Although we know the mechanism of action, previously we have discussed all these, but now in therapeutic concentration, this phenytoin produces changes in all these. Changes in the conductance of these ions, changes in the membrane potential, or even changes in the concentration of these amino acids, norepinephrine, acetylcholine, and GABA-like chemicals and neurotransmitters. And those usually there is a prolongation of the sodium conductance, especially inactive state of the sodium conductance, when the drug molecule phenytoin bind with the membrane lipids. When the concentration of phenytoin is very high, it can also inhibit the release of serotonin and norepinephrine, or it promotes the uptake of dopamine, or it can inhibit the monoamine oxidase enzymes activity, or there may be decreased calcium influx. Thus, there may be inhibitory effect on the secretive process, especially release of hormones or release of some neurotransmitter. Or there may be effect on the increased responsiveness to GABA and other effects also. There may be increased activity of GABA and other inhibitory neurons. Obviously, the most important pharmacological effect is only in the brain. So, phenytoin exerts its antiseizure activity without causing generalized sensory depression, without causing sedation. However, in toxic doses, phenytoin may produce even excitatory sign, and if a further increase in the lethal dose, there may be a type of decerebrate rigidity, like cerebellum have been removed, and there may be prolonged contractile state of the body, like tonic type, severe contractile state of the body. Now, in this graphic representation, we have 5 drives, and that shows the zero order correct, that is characteristic of phenytoin. We have already discussed this aspect in general pharmacology, but here we see there is non-linear curves because the metabolism of phenytoin is saturable. So each drug can show different level and different types of these graphs. Due to that reason, the half-life of phenytoin may vary in individual cases. It usually varies from 12 hours to 36 hours with the average of 24 hours. When the blood levels are low, like in therapeutic dosages, the steady state may be achieved after 5 to 7 days. Remember, in non-zero, that is first eukaryotic, usually after 4 to 5 half-life, we get the steady state. But in this case, usually it may vary. But when the levels are even high, toxic levels, this steady state concentration may require up to 4 to 6 weeks to reach at the stable level. So that's a typical with the zero order kinetic activity. As far as the uses are concerned, obviously, first of all, epileptic and non-epileptic uses. Obviously, epileptic use include in prevention of the especially focal onset of seizure, and as we have seen before, partial and generalized tonic-clonic, and even if idiopathic origin is there. And it is one of the most important drugs useful in status epilepticus. So these were the epileptic uses. Among the non-epileptic too, in the neuralgias and cardiac arrhythmias. But in neuralgias, especially facial type of neuralgias, carbamazepine is preferred than the phenytoin. But in cardiac arrhythmias, we have already seen in the classification of antiarrhythmics that phenytoin is one of the important drugs useful for acute and chronic ventricular arrhythmias, and even digitalis induced arrhythmias also. So these uses are important as far as the examination point of view is concerned. Remember, it worsens the condition like primary generalized epilepsy or absences we have seen, or even juvenile type of myoclonic epilepsy, or some other Dravet syndrome, or maybe worsen. So that is why phenytoin should not be used in such condition of fits and epilepsy. As for the toxic and adverse, toxicity, because due to zero autokinetic, we can easily get toxic level of phenytoin. So that is also important. But even in the normal therapeutic range, adverse effects are very important to observe. Obviously, these depends upon the route of administration, whether we are using orally or we are giving it through parenteral route of administration, or for how much time we are giving these drugs, and what is the dosage we are using of these phenytoin. Accordingly, toxicity and adverse effects may vary. So that means all these effects may be dose related. Usually early signs of toxicity or adverse effects are on the CNS. There may be nystagmus due to severe effects on the extraocular muscle of the eye, or even there may be diplopia, or in the skeletal muscles of the limbs there may be ataxia. Remember, sedation is not seen with the normal dose, only seen at very high toxic level. It may also show some abnormality in the vestibular part of the cerebellum, or even the behavioral changes. And there may be increased frequency of the seizures also. And next important early sign of the toxicity is the hirsutism. And this may be very annoying, especially in the young females. But however, if we decrease the dose, we can decrease the symptoms of hirsutism in the young female. After long-term use of this phenytoin, we have seen gingival hyperplasia. This is a characteristic gingival hyperplasia. There may be alteration in the collagen metabolism of these sites, and this is the most common toxicity, especially in children and even young adults. However, it can be minimized by good oral hygiene, but even then, the gingival hyperplasia cannot be absolutely eliminated. Even in the young patient, there may be coarsening of the facial features. Nose may be settling type, suppressed or depressed. There may be some mild peripheral neuropathy that may be indicated as a diminished deep tender reflexes, especially of the lower extremities. And next important one is the development of osteomalacia. This osteomalacia is usually actually due to abnormalities of the vitamin D metabolism, or there may be some inhibitory effect on the intestinal calcium absorption. Remember, there is some increased metabolism of vitamin K dependent protein, which is important for the normal calcium metabolism in the bone. So that is why commonly this type of osteomalacia is not responding to vitamin D supplement. There may be some low folate levels also that may lead to produce megaloblastic anemia. And remember, phenytoin is also a very well-known enzyme inducer which can decrease the drug level of so many other drugs. Some other rare adverse effects, but even that may be important ones. Some hematological reaction, as I told you, very rare, but there may be neutropenia, leukopenia, aplasia, especially RBCs cases, and there may be agranulocytosis or even thrombocytopenia, though rare, but still seen. Or there may be hypoprothrombonemia, and there may be hemorrhages also. These are seen especially in newborns of those mothers who have been receiving phenytoin during pregnancy. And vitamin K is effective treatment, as not only as a treatment but prophylactically also. We can give vitamin K to such pregnant ladies to avoid these side effects. We have also seen some lymphadenopathy in such patients. And this lymphedema is associated with the reduced immunoglobulin type A specially production. Although rare, but some idiosyncratic reaction is also observed with phenytoin. Or apart from idiosyncratic reaction, there may be some allergic reaction, hypersensitivity in the form of skin rashes, or even Stevens-Johnson syndrome, which is very serious one. There may be severe and exfoliative type of skin lesion, or even fever may be there due to allergic reaction of the drug. We have seen some systemic lupus erythematosus like problem in few of the patients with the phenytoin. Or potentially there may be fatal hepatic necrosis in such patients, though rare but have been observed. Adverse effects can also be memorized through this word phenytoin, Phenyoin, P450 interaction, H for hirsutism, N for nystagmus, Y for yellow browning skin, O for osteomalacia, and I for interference with the B12 metabolism, megaloblastic anemia, or N for neuropathies, even vertigo, ataxia, headache, etc. Now the next important drug is the carbamazepine. Remember, its mechanism similar to phenytoin. At therapeutic concentration, it blocks sodium channel and inhibits the high frequency repetitive firing action potential. It acts both presynaptically and decrease the synaptic transmission, or potentiate the postsynaptic action of the GABA, increasing inhibitory effect of the GABA. However, it has no effects on the spontaneous activity or on the responses to GABA or glutamate. It has one of the active metabolites, 10 and 11 epoxy carbamazepine, which has similar type of anti-seizure activity. So the anti-seizure activity may be having a prolonged duration due to this active metabolite. Now, as far as the uses of carbamazepine is concerned, again, epileptic and non-epileptic uses. Epileptic, again, partial seizure and generalized tonic-clonic seizure. But non-epileptic, trigeminal neuralgia, very important drug to be used, this trigeminal neuralgia type, or some psychiatric problem like bipolar affective disorders, and even in case of mania, this carbamazepine is still used in such psychotic and psychiatric problem. As far as the toxicity is concerned, its acute toxicity can result even severe stupor or coma. Our patient may be in a state of hyper irritability or some development of convulsions, but it can depress vital center including respiratory center. Apart from acute, with the long-term therapy, it can show drowsiness, vertigo, ataxia, diplopia, and even blurring of vision. The frequency of seizures may increase, especially with the overdose. It can induce some types of fits-like problem. Like phenytoin, other types of adverse effects include nausea, vomiting, and serious hematological toxicity, including aplastic anemia and agranulocytosis, or some allergic reaction, hypersensitivity, including skin dermatitis, eosinophilia, or lymphadenopathy, and even we have seen splenomegaly with the use of carbamazepine after chronic use. There may be some late complications of carbamazepine leading to water retention with a decrease of osmolality and hyponatremia. And this is especially elderly patients who are known cardiac patients also. It also shows some development of tolerance, especially to the neurotoxic effect. And these effects can be minimized if we gradually increase the dosage. Don't use full dosage initially. Gradually go on increasing, so then we can delay the onset of tolerance with the carbamazepine. It can also cause transient elevation of some hepatic enzyme transaminases up to 10% of the patient. There may be some mild leukopenia up to 10% of the patient, especially during initiation of therapy. But this transient mild leukopenia may be resolved within first 4 months of continuous use of treatment with carbamazepine. Apart from transient mild leukopenia, there may be transient thrombocytopenia. Up to 2% of the patient, there may be persistent leukopenia. And if that happens, then you should withdraw the drug carbamazepine. As far as the aplastic anemia is concerned, that have been seen, although very rarely, who are on carbamazepine. But remember, it's not clear whether periodic blood tests should be done, because this aplastic anemia is irreversible with carbamazepine, although very rare, 1 in 200,000. There will be some induction of fetal malformation in the pregnant ladies who are on carbamazepine. So it should be used very carefully. And lastly, the drug interactions of carbamazepine. It can also induce the metabolism of phenytoin, primidone, clonazepam, valprovocation, ethoxyzumide, so leading to decreased levels of the drugs. Now, thank you very much. This is the end of the second part of our discussion regarding the antiepileptics. Now we will see in the third part later on. Thank you very much.